Hello, I'm Dr. Marquita Norman, Associate Professor of Emergency Medicine at UT Southwestern Medical Center. The next topic in our Race and Racism module is effects of racism. Authors have no conflicts of interest. Our objectives for today are to describe how race and racism affects emergency medicine care directly between provider and patient, describe how racial bias and microaggressions affect emergency medicine at the training, hospital, and healthcare system level, minimizing diversity of the healthcare workforce, and to describe how race and racism interacts with other social determinants of health affecting emergency medicine care at the societal level. Racism has effects at multiple levels, including the bedside, hospital, health system, and societal levels. In the emergency department, we are confronted with quick, life-saving decisions daily. We are at high risk for actions based on implicit bias resulting from incomplete information, which can have unintended consequences as it relates to patient care. The bedside level refers to the effects of racism that can be noticed by the individual patient. Known disparities at the bedside level include disparities related to pain management, for example, sickle cell disease patients and pediatric patients presenting with pain. Implicit bias in emergency medicine contributes to disparities in pain management for Black and Latinx patients. Studies show that these patients are systematically undertreated for pain compared to their white counterparts, even when pain scores are taken into account. This highlights a significant issue in emergency departments where marginalized or historically disadvantaged groups are less likely to receive opioid analgesia for conditions such as long bone fractures, back pain, and abdominal pain. The heart failure risk score predicts the risk of death in patients admitted to the hospital. It assigns 3 additional points to any patient identified as non-Black, thereby categorizing all Black patients as being at a lower risk. Since Black is equated with lower risk, following the guidelines could direct care away from Black patients. In kidney transplantation, the Kidney Donor Risk Index, implemented by the National Kidney Allocation System in 2014, incorporates donor characteristics, including race, to predict the risk of kidney graft failure. Notably, the race adjustment is based on the empirical observation that kidneys from Black donors tend to perform worse than those from non-Black donors, regardless of the recipient's race. When a potential donor is identified as Black, the KDRI returns a higher risk of graft failure, potentially marking the candidate as a less suitable donor. This raises concern because Black patients in the United States already experience longer wait times for kidney transplants compared to non-Black patients. Given that Black patients are more likely to receive kidneys from Black donors, any factor that reduces the likelihood of donation from Black individuals could contribute to the disparity in wait times. The issue of the KDRI may exacerbate this issue. The use of the KDRI may exacerbate this issue by potentially discouraging Black individuals from becoming donors or by reducing the number of kidneys available from Black donors for transplantation. For example, this review article examined racism in healthcare as it relates to older African American adults. In the United States, there have been extensive medical advances over the past several decades. Individuals are living longer, and illnesses that were deemed terminal in the past are now considered chronic illnesses. While most individuals living with chronic illness have experienced a better quality of life, this is not the case for many African American older adults. This article summarized that older African American adults are less likely to have their chronic illness sufficiently managed and are more likely to die from chronic illnesses that are well controlled in whites. African American older adults also continue to suffer from poor health care outcomes throughout the lifespan to end of life. Effects of racism at the hospital and healthcare system level. These disparities we've noted are indeed concerning and reflect a broader systemic issues within the healthcare systems. Structural racism, as mentioned, plays a significant role in shaping access to care and ultimately health outcomes. Factors such as historical patterns of segregation, discrimination, and economic disparities have created unequal distributions of healthcare resources, leading to disparities in quality of care and health outcomes. The correlation between race, socioeconomic status, and access to high-quality healthcare is evident in the disproportionate representation of historically disadvantaged demographic groups in lower-performing hospitals and communities with fewer resources. This perpetuates a cycle where individuals from marginalized communities face barriers to accessing the care they need, leading to poor health outcomes compared to their counterparts. Limited resources in healthcare systems serving underrepresented communities result in emergency department overcrowding and unequal implementation of evidence-based care. This overcrowding often leads to ambulance diversion, a situation that occurs more frequently in hospitals catering to a high share of patients from marginalized or historically disadvantaged groups. Ambulance diversion can also adversely affect patients, causing delays in time-sensitive interventions. Additionally, when hospitals predominantly serving minority populations experience high rates of ambulance diversion, it may signify a fundamental imbalance between the supply and demand of emergency department services. These systemic issues related to ED overcrowding can further exacerbate delays in the delivery of life-saving therapeutic interventions. To address racial and ethnic disparities in healthcare, it's crucial to recognize their roots in historical and ongoing social, economic, and racial discrimination. This context shapes the disparities we see today. Throughout history, physicians and scientists have championed the belief that Black people were fundamentally and biologically different. This belief was used to justify inhumane treatment in medical research. An example of this includes the Tuskegee experiment. Some of the most notable consequences of structural racism are evidenced by the wide disparities in emergency department care and utilization, which are associated with poor outcome management of chronic conditions. Racial and ethnic disparities are also evidenced by a disproportionate burden of infectious disease in Black, Latinx, and Native American communities. Factors such as limited access to health care, higher rates of underlying health conditions, crowded living conditions, and systemic inequities contribute to higher rates of infection and poor health outcomes within these communities. African Americans account for about 13% of the US population, yet represent almost half of new AIDS diagnoses. More recently, African American, Latinx, and Native American populations represented a disproportionately higher incidence of COVID-19 infections compared to their white counterparts, and a higher morbidity and mortality based on population per capita. Another consequence of structural racism is the development of maladaptive patterns of interactions with the healthcare system among marginalized communities. This can manifest in various ways, including distrust of healthcare providers and institutions, reluctance to seek care due to past experiences of discrimination or mistreatment, and a lack of adherence to medical recommendations. These patterns can further exacerbate disparities in healthcare outcomes and access to care, highlighting the need for culturally competent healthcare practices and efforts to address historical and systemic injustices within the healthcare system. In this conceptual report, the third in a series on equity and equality in health in the USA, the authors use a contemporary and historical perspective to discuss research and interventions that grapple with the implications of structural racism on population health and health inequities. They argue that a focus on structural racism offers a concrete, feasible, and promising approach towards advancing health equity and improving population health. Now we have a few questions for discussion. Our first question is, name one effect of racism at the bedside. Question number 2, name 2 effects of limited resources in minority serving healthcare institutions. And question number 3, name 2 infectious diseases associated with disparities in minoritized communities. Now we will discuss the answers to the previous questions. So one effect of racism at the bedside can be any of the following that were given as examples, including provider bias, pain management, the heart failure risk score, or kidney transplantation. Two effects of limited resources in minority-serving healthcare institutions are racial minorities or minoritized individuals more frequently receive care in lower performing hospitals, and ED overcrowding and unequal implementation of evidence-based care. And two infectious diseases associated with disparities in minoritized communities include COVID and HIV/AIDS. This is a list of our references, and these are the contributors to this topic. We thank you for your attention.